Hey everybody, thanks for joining me once again. We are here with my friend Ashley Campbell, who's gonna help us do a little bit of a deep dive today on how to differentiate hip pathology with low back stuff. That can be tricky in the clinic, we know. And then she also uses high power laser. So Ashley, welcome. Thanks for joining
Thanks for
me.
having me. Glad to be here.
Yeah, so your day job, you reside at the Nashville Hip Institute at TOA. Maybe you can talk a little bit about, your unique clinic environment so people understand
Sure.
kind of what your day-to-day looks like.
Sure, absolutely. So, yeah, I am the director of rehab here at National Hip Institute at Tennessee Orthopedic Alliance. I work directly with Dr. Thomas Bird, who is a hip arthroscopist. I've been here with him going on 10 years this December, and interacted with him and worked with a lot of his patients in my previous life as well for several years. So I've spent the last decade basically learning about these non-arthritic hip pathologies, all the extra articular stuff around the hip, and then just kind of the layers of stuff that come along with your FAI type patients and otherwise. So we have a really unique environment where we see a lot of people from out of state, out of town that come in for evaluation and plans. A lot of people that have been seen a lot before. So we do a lot of figuring out. And actually having something like a high powered laser is like a nice little handy thing to make some really quick change. I'm sure we're going to get into a lot of talking about this today, but to make some quick change on pain to prove some different points to patients when you're doing evaluation, you have to be able to show them things in one day, one visit. I don't get 3, 4, 5, 6 visits to kind of prove my point to patients that come from out of state. So having some quick modalities that are very effective at hand are really helpful. And then my other piece of my role with Tennessee Orthopedic Alliance is I do all of our internal education. So I spend a lot of time kind of teaching our clinicians, our residents about utilization of all the things that we're going to talk about today, and particularly on the hip.
And I think it's important to point out at your center, you have not only, a surgeon that is the center piece of the center, but you also have an interventionalist, right? A nurse practitioner, and then you
Yep.
have a full PT department. So can you just talk a little bit how you guys work together
Sure, absolutely.
with the
Yeah,
average patient who comes in?
I think that is it's just such a special place to work. It's something that's not very common. It certainly exists elsewhere, but it's certainly a rarity, particularly as a therapist, to have the environment that we have. So we have Dr. Bird, who's obviously orthopedic surgeon, specializing in hip arthroscopy. Beth Bardowski, who is our nurse practitioner, who's been with Dr. Bird for 13, going on 14 years, who is by far and away, at least in the US, the expert on ultrasound injections about the hip and assessment of the hip with diagnostic ultrasound. So that's very helpful for us. And then we have a full PT department. So myself as the director, one, two, three, four physical therapists and a PTA. Who all work here. So patients come, they spend usually the day with us. They get a PT evaluation. They meet with Dr. Bird. They usually get imaging, X-ray, MRI. They meet with Dr. Bird again to go over said imaging. They very often get a diagnostic injection or a series of diagnostic injections. And in between those injections, they have a reassessment with physical therapy to look at what's better strength wise, what's better range of motion wise, pain wise, functionally, what's better. And that helps us give them a very specific diagnosis and a very specific plan for what they have going on with them. And as we talk about this relationship between the hip and the low back, that experience is super helpful in the patients that do have overlapping signs and symptoms, because it can be hard to tease out without the use of something like a diagnostic injection.
Yeah, so hopefully you listeners out there, you get a sense we're talking with somebody that looks and touches and deals with hips every day. So just keep that in mind as we have this
Thousands.
conversation today. Yes, yes. So obviously you just said you attract patients that come from all over the country and the region, to come to you. What's your most common patient you're seeing in your center for
Sure.
hip?
I would say, by far and away, our most common presentation is what we would call FAI syndrome. So femoral acetabular impingement syndrome, those that have underlying hip morphology of hip impingement, but also have pain associated with that. The problem with that is multiple fold. While it sounds pretty straightforward, oh, you have hip impingement and labral pathology, you probably need a surgery, right? That's how most of them end up in the door. Like someone told them that they're here, they're hoping to get signed up for a surgery to fix their problem. But unfortunately, as we know and have learned a lot over the years, there's a lot of layers to that. And in addition, I would say the second most common person I see in that population is those with intra-articular hip pain and layers of other things going on who have had 1, 2, 3 plus previous hip arthroscopies already and are now seeking us for failed hip surgery. And what do I do now? And that, unfortunately, in the last 5+ years has become a much more common thing than not. So I would say when I first started with Dr. Bird, like 20% of my patients had had a previous hip scope. And now I would say closer to 50 to 60% of the people I see and evaluate on a day-to-day basis have already had a hip surgery somewhere else and are coming to us because they feel like it didn't work.
And, a couple questions come to mind. What makes that diagnosis of impingement so tricky for the average clinician to try to tease out? Like why do people scratch their head and sometimes just say, hey, I got to refer you over to a hip center because I'm just not sure what's going on? What makes that so challenging to really pin down?
Yeah, I would say there's a lot of things. I would say a big piece of it, we talk about FAI, particularly cam morphology, being kind of the silent killer of the hip. Dr. Gons kind of coined that. And it's because with that cam impingement, you're getting this repeated stress on articular cartilage, which doesn't have, it's aneural. So even though it's getting stressed and beat up, you don't start to get pain from the wear and tear of the articular cartilage until you start getting into more like grade 3+4, where we're getting some small amounts of bone exposure where there's some nerve endings, or you've beat up the labrum so bad, which is highly neural, that it starts to become painful. So these patients seemingly have pain that just came out of nowhere, right? And they're like, I have no idea what happened. There wasn't an injury, there wasn't an instance. Sometimes there is traumatic, but they're like, I don't know, I was fine and now I'm not. And the other weird thing or tricky thing about these patients is the symptoms will definitely flux. And sometimes it's hard to pinpoint like why they're fluxing. Like some days I feel great, I can do anything I want to do. I can squat, I can run, I can jump, I can do whatever. And then 5 days later, I can't do any of that. I can barely get out of bed. I'm miserable, and it'll wax and wane a lot. And so they're like, if there's a pathology there, shouldn't it always be painful, right? Like if I tore my hamstring, I would probably consistently be painful with a torn hamstring every day until it started to heal and those sorts of things. So why with a labral pathology or intra-articular pathology can it kind of do this roller coaster for months, years? So I think that makes it very tricky. And because of that, patients delay seeking care because they're like, make an appointment and then they're like, well, I've had a month where I feel great. So why would I go to the doctor if I feel fine? And
Right.
then by the time they actually go, now they have all these compensatory problems that the therapist is like, or the doctor is even like, I don't know. I don't know if it's your back. I don't know if it's your hip. I don't know if it's both. I don't know if you're crazy. And a lot of times by the time they get to us, they're like, I think I'm crazy. And 99% of the time, they're not crazy. They've just been kind of led to think like, it's all in your head.
Right, right. So you mentioned some of these folks that get referred to you, they're not surgical candidates based on your findings. How challenging is it to talk those patients off of that ledge that know you don't need surgery? And how important is it to get a quick change in their presentation via helping relieve symptoms to get them on board with what you're telling them?
I would say more people than not come in and say, well, I don't want surgery. But then all they talk to you about is like, well, when am I going to talk to Dr. Bird about my surgery? So I would say the difficulty lies in like their true underlying desires. There are people that come in and when I tell them like, look, I don't think you're going to need surgery. I think we can get this. And they're like, oh my gosh, thank you. And they're like in tears, so happy. Those I don't get, those I'm not as hard pressed to like make this quick, rapid, prove my point change. But at least half of the people that walk in the door and they have to see me or one of my therapists first. And we have to be the ones to break it to them that Dr. Bird's not going to offer you surgery today. That doesn't mean, then here's the big thing that has to come across from us and from Dr. Bird is not right now doesn't mean never, right? So telling someone like, I don't think we need to operate on your hip right now doesn't mean that we're never going to have to operate on your hip. It means that right now is not the right time. We need to tease this out a little bit. We need to pull back some of these layers of compensatory problems you're dealing with so that if you do need a surgery, you have a better outcome. And setting that expectation is really important. And so in those patients, having the opportunity to make a really quick, effective change in how they feel, it doesn't mean it's going to last forever. It's not going to be the be all end all to all of their problems. But if I can take someone who is in pain and demonstrates, objective weakness on, like, say, a manual muscle test on the table or multiple manual muscle tests, and use a modality or a treatment such as high powered laser and drop their pain significantly and retest that same thing and see an objective improvement that they themselves can even see, that goes a long way in being like, see, I think we have some room for improvement. Again, I'm not saying that you're out of the woods on needing a hip surgery, but I think we can make some good gains. And then if it comes down to needing a hip surgery, you're going to be in such a better place to go through that surgery, recover from it, and do the things that you want to do after that. And more times than not, if that is done well, they appreciate that. They then go talk to Dr. Bird and they hear the exact same conversation with the surgeon, telling them, I'm not telling you that you're not going to need hip surgery, but you need to do what my therapists are saying so that we can get you better prepared if you do need one. And most of the people will walk out of here thankful that they've got a very thorough evaluation and a good plan to go home with.
Yeah, and you mentioned that a lot of these folks that are trying to play the game of not getting surgery or not having this looked at do create a lot of compensatory changes in their system, whether it's hip, back, or what have you. So a lot of the folks that are probably tuned in today, they're not hip specialists. What pearls can you maybe give them? Because it is important to try to clean out, those issues going on in the low back, as well as maybe glute, SI, things of that nature.
Yeah.
What should they be trying to do, or what differentially can they do to take a look at that person and go, wow, this looks like this has, on a weighted scale, a lot more to do with their low back today than it does their hip, or vice versa?
Sure. Well, anytime someone comes in and tells me that some of their primary symptoms are pain traveling down their leg, particularly past their knee, back has to go on the table for me in some form or fashion. If that traveling pain stops at it's more lateral and stops at the lateral malleolus, glute med min is on the table for me, because that can actually refer down. And it took me like years of telling Dr. Bird that to convince him that patients with hip issues could have pain that went past their knee. He believes me now. But if it goes into their foot, back is on the table. There's nothing, to my knowledge, in 10 plus years of digging into this, that specific at the hip and isolated to the hip is going to travel into the foot. So if it's going into the foot, back has to be on the table. The other big thing is numbness and tingling. And the way that patients describe symptoms, I have learned over many, 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 many evaluations, can be very different things. Like what someone describes as numb sometimes is more of this like deep ache that travels down their leg. That's more pain versus like what we think of as a true, like, oh, you have compression of a nerve and your leg is truly numb. So sensory testing is very important. Like, can you feel this? Is it symmetrical? Yes, I feel you touching me. And yes, it feels the same, but I'm telling you it's numb. Well, then that's not actually numb like we think about it as therapists. So little things like that are important to not just take what the patient is saying at face value. If you suspect, disc pathology, repeated movement testing is a super easy way to you're either going to flare their symptoms up or you're going to decrease their symptoms. And if I can make changes with, straightforward repeated movement testing at the spine, then I can educate the patient on I'm specifically assessing your back and your symptoms are changing. So your back is still on the table. Whereas if I do bend their back 6 ways to Sunday and they have no change in their symptoms, their back's probably just a compensatory, like, yeah, my back hurts. Okay, well, most people with hip pain for a long enough time, their back hurts too. You may be planning to ask me about this, but specific to like looking at the hip, if I see that they have super restricted range of motion, it's particularly with rotation, and they're also having back pain, and oh, by the way, their favorite thing to do is play, 3 rounds of golf every weekend. Well, their back, I'm not surprised their back hurts. If you're trying to rotate around hips that don't have any motion, the motion's got to go somewhere. And that's typically going to be the lower back and or the knee. And so things like that.
For your hip impingement patients, their pain presentation, what's the classic that they're going to talk about when they roll in?
Yeah, if you're in this, it's so funny because I like jump to the more complicated stuff first now, because that's just more commonly what I see. It's an amazing day if I see a straightforward, you have FAI syndrome and you don't have any compensatory crap going on. Those people will walk in the door. They'll usually have like what we call C-sign pain. So they'll cup their hand and kind of wrap it around their groin. Like, it hurts. I'll show you, like, they'll walk in and be like, where does it hurt? It hurts right here. And they'll do that. Or let's say like it hurts, or it hurts deep in here. That's a classic, like, okay, your joint is hurting you. Different from if they come in and they say it hurts here. Okay, now adductor, core muscle injuries may be on play, or if they're pointing like up in their abdominal region, I gotta tease out core muscle injury and those sorts of things. But a classic, straightforward hip joint pain person will come in pointing in some form or fashion to the deep groin crease. And they will typically complain of things that are rotary in nature or quick movements. It hurts if I like turn quickly, or if I like get in and out of the car, put on my shoes and socks. They usually won't complain much about straightforward motion. Steps won't bother them. Walking typically won't bother them unless they're walking super long distances. But that's kind of the classic, just straightforward FAI syndrome patient.
And I think the other big category of hip patient, you see a lot of it is these glute med pathology type patients, people with tendinosis in their glute med. Can you talk a little bit about how they show up?
Sure, absolutely. So like we use the kind of this lump term, greater trochanteric pain syndrome is kind of the common terminology these days. But that can be a really wide spectrum of diagnoses. If I'm going to be concerned about true gluteal like pathology, tears, or severe tendinopathies, if they're female, if they're saying their hip hurts laterally, so they're pointing to their lateral hip, and they're female, it's going up. If they're female and they're between the ages of like 40 to 60 plus, it's going up. If their chief complaints are, I get up from sitting and I have this like startup pain in my lateral hip, and then it feels better after I walk a few steps, but then if I walk too long, it gets really bad. Probably some glute involvement. Stairs are going to be problematic for those with glute involvement. Inclines are going to be problematic. They won't be able to sleep on their affected side. If it's bad enough, they won't be able to sleep on the uninvolved side either, unless they have a pillow between their legs, because that adduction of like crossing your legs over if you're side lying, that'll stress the abductor. So those would all put that super high on my list of they likely have some form of gluteal involvement. Certainly you can't rule it out for men, you can't rule it out for younger people, but in those instances, it's typically more of like a compensatory side effect of something else going on versus the root cause, like what we call a primary abductor pathology.
And I have to ask this question just because when I was treating patients a million years ago,
I feel like I know where this is going to go.
One of my biggest pet peeves was I'd get the script that said trochanteric bursitis. And you look at this hip for 3 seconds, poke around their glutes, or you do a hip scour type test, and it's like it lights up like a Christmas tree. How often do you see a true trochanteric bursitis in your center?
An isolated trochanteric bursitis? Never. Never. Ever.
Thank you. So
like, I wish Beth was in here.
For those folks out there that are thinking, oh, you got a bursitis, sir, or ma'am, you ever, just don't even say it.
My favorite ones are the ones that they've been diagnosed with trochanteric bursitis. They've had multiple laterally based injections of cortisone and have never felt better. Right. If it is an isolated trochanteric bursitis and you shoot cortisone into that area, it better damn well feel better.
Right. I love it. I love it. I feel vindicated, Ashley. Just made my day.
You are so, and I'm mad because you asked me, like, do you have any papers? And if I would have known about that topic, there's a really good paper, and I can send it to you, on imaging studies where they looked at like 200 plus people with lateral hip pain, and they looked for who had true isolated trochanteric bursitis, and then who had it like in combination with glute tears, whatever, like all this. It was under 2% were identified as isolated true. And I bet if we would have looked at those images, we would have found something else that.
Right. So switching gears just a little bit, I mean, you're an expert in functional testing. Do you find that there's one or two on that list of your functional tests that will light up like as a positive for people with, impingement or, some sort of hip true pathology on that screen?
Yeah, it definitely is more variable than you would think. Classically, most people think like, oh, FAI squat is going to light them up. And oftentimes it does, especially if it's super irritable. But someone who's a little bit of a higher level athlete, who maybe isn't overly irritable at baseline, it takes a lot more physical activity. Sometimes they can deep squat perfectly fine, without any pain. Now, sometimes they can squat with no pain, but their mechanics are really poor when they have very large cam impingement or that sort of thing. So with those people, then I go into like more aggressive testing. So maybe a single leg squat, or we get into more lateral lunges or more like jump lunges, something a little bit more dynamic. Um, Multi-segmental flexion, or just, your standard forward bending, for some people with hip issues, that will get them. But very important when people are like, yeah, that hurts, to ask them where, because a lot of these ones that are kind of coexisting low back hip, they bend forward, they're like, that hurts. And it's important to know, like, does it hurt your back or does it hurt your hip? And a lot of times it actually hurts their back more than anything. I would say you find limitations very commonly in like just looking at whole body rotation. So I just do feet together, rotate as far as you can each direction. People with hip pathology will typically be pretty limited in that. And then if
Is
we're
it usually
talking,
limited going towards the involved side or away?
so more often than not, they're going to be restricted turning into their side of involvement, so that internal rotation. But there's times where it's also limited external. Some of that depends on their underlying anatomy with like their femoral version and things of that nature. But they usually will have some restriction in just load bearing rotary motion. And then with the gluteal pathologies, if we do single leg stance and that causes a pretty quick increase in their lateral hip symptoms, glute pathology rises up my list even more.
So I hear from a functional screening standpoint, it's kind of a yellow light, like it might give you some ideas, but you're gonna have to do a little more digging. Yeah.
Yeah, I would say there's definitely some things I see some consistencies, but I mean, it's a piece of my puzzle, but it's certainly not gonna give me all my answers.
So Ashley, as far as like how you're incorporating this with, your acute, chronic, and subacute patients, how do you find it really helps with your acute patients, that come in are really tender and are having trouble with maybe even weight bearing or
Sure.
activating their soft tissues?
Yeah, so acutely, we know that we can use the high power laser to address the pain associated with any of that acute inflammation that they have. So I'm really like that's my primary goal, right? Reduce their pain so that they can move better. My goal is always getting them off the table as quick as possible, but that may even mean just getting them decreased enough to tolerate manual therapy for the day. So, and we may use it at the start of the session, and we may use it again at the end of the session, just to kind of, it's almost like that little cherry on top at the end of it.
Because I get asked that question a lot, should we do laser before or after? And, my answer is always it comes down to intent.
Sure.
So if you have somebody who's sore from a vigorous day in the clinic, it might be used to help minimize their symptoms as they walk out the door and feel better,
Right.
hours down the road as they get better blood flow and what have you. But I'm sort of always the champion. I'm like, if you have your druthers, to do it early on if there's a lot of muscle guarding and pain, because as you knock that down, it just opens up the playbook on things that you can do. Is that
Yeah.
how you look at it?
Yeah, I would definitely say more times than not, we're utilizing laser as like our prep work, kind of our tissue prep, warming the tissue, bringing more blood flow, all of those things. But like you said, yeah, if I'm like, you know what, I really pushed this person today, like we took it up 2 notches, not just one, maybe doing it at the end of the session. Even if we maybe used it for prep, that's okay too. We might just would do it quickly at the end of the session, just hoping that it's going to help not have as bad a DOMS, that sort of effect.
And I think for especially the hip population, it's so important to have them try to walk out with a normalized gait. If they're sore or fired up from what happened in that session and they're going to go
Yeah.
back to their old bag of tricks, I mean, that's not helping the process.
Yeah.
So,
And that
uh,
happens. Like we'll get to end and all of a sudden I'm like watching them like go to grab their keys. And I'm like, are you limping? Like
whoa, right.
I'm just a little sore. And I'm like, okay, hold on. You got 2 minutes? Like, hold on real quick. Like let's just pause. And that's the nice thing about having a high powered option is the quickness of it. So it's not like crap, great. Like, well, I don't have 10 minutes to knock out a different like a different modality or some manual or anything like that. But I do probably have 2.5 minutes that I can do this. So yeah, it's a nice option to have.
And you said you use it on most patients. What is your common feedback you get when you use it on them? Do they know what it is? Are they surprised by it? Do they like it? What's the feedback you
Yeah,
get when
I
you
would say in the athlete world, they mostly know what it is these days, especially the pros or the college. I would say more even average persons than not are starting to know, or at least heard. Like, have you ever heard of laser? Do you know the difference between high power and lower power pulse laser, or whatever? So we try and educate them a lot on it, what the intent is, why we're using it. I would say 99.9% of patients love it. I mean, obviously it's a passive treatment, so they don't really have to do any work. And most people like the warmth, the heat. They like that it kind of feels like it relaxes their tissues. So yeah, and then if you don't do it, I'm like, are we not doing the laser today?
I'm getting shortchanged,
Yeah,
right?
and then you're like, then you have that like guilt, like that therapist guilt, like, well, you don't really need it, but like now I feel bad because I know you like it. Like we're just so bad about that. I'm like, okay, fine, hop on the table, we'll do it real quick.
Right, right. So you guys do a lot of injections at your center, and I get asked a lot, like, "Hey, can I do laser? After an injection, or how long should I wait, or what have you?" I mean, I think our recommendation is generally wait about 2 weeks because the concept being you're going to put, this vasodilating treatment on the area and maybe wash away the cortisone that's been placed in the joint. So you don't want that, obviously. But
Sure.
how do you guys, from two points, when do you introduce laser after you do an injection, and B, how do you intertwine those two therapies when you have something that needs that?
Um, I really don't put a significant time limit on it. And those that were injecting their hip joint, we usually wait a week before we see them back in therapy anyways. And at that point, like I'm fine with laser because generally at that point, their joint feels pretty darn good. And really what we're trying to do is address any of the soft tissue dysfunction around the hip. So we're using the laser with the mindset more towards addressing the soft tissues versus trying to really get to the joint. And I haven't studied this, like, but anecdotally, I've never had a situation where I've started to be like, I wonder if we're using the laser too soon because these people's injections aren't like lasting or they aren't working. That hasn't happened at all. And I would say we more times than not are using the laser within their first or second visit back after their injection, which again is typically 5 to 7 days at least. So our hope is that injection has kind of started to do what it needs to do. We're not too worried about anything.
And I know at your center we talked about the possibility of doing a little bit of research on the idea of using laser maybe in place of an injection, and there were some hurdles and pitfalls of that. Can you just sort of talk a little bit about that? Was there any success when maybe some patients were able to avoid injection, or is it just not something that worked well with the flow of how you guys manage folks?
So big difficulty with that is if they're coming from out of town, we don't have a I don't have a list of hundreds of places that happen to have your laser that I can be like, hey, go get 6 sessions of this before you get a hip injection. So that grouping is almost off the table for throwing out the injection. But the local patients that are going to come regularly for therapy, the ones that the joints are a little harder to be like, yeah, we should wait. Versus when I say joints, versus the people who have a lot more soft tissue dysfunction, a lot of like abductor pathology or extra articular stuff that we really need to deal with, where I might be like, hey, before we use that injection, like, can I get 3 or 4 therapy sessions where we can use our modalities, use our skill set to see if we can actually do this without an injection? And that's usually the people who don't have substantial hip joint irritability. So when I move their hip around, they're not coming off the table. They're like, yeah, that's not comfortable, but it's fine. Those are people that if they're local and able to come see us and get the treatments, then we can kind of dabble with that. And it's not like they're just coming and just getting laser. They're coming and they're getting laser and other modalities, and then they're also getting therapeutic exercise, manual therapy. But yeah, in that population where it's like their joints a little irritable, but honestly more than anything, like their back's bothering them, their lateral hip muscles are bothering them, their adductors are irritated. Those are the ones that introducing laser as one of the options within their treatment plan can actually help us have some success of keeping them away from an injection or at least delaying it to some extent.
I think that's super useful because I think a lot of clinicians are always thinking when they have a hard patient or somebody who's not maybe progressing, or they're wondering, based on, maybe a complaint of a C type, hand on their hip, and they're like, wow, that sounds like a hip problem. Do I need to refer them for injection or not? I think that kind of information is very useful for those folks to know, hey, maybe you can, if it's low level, try to
Yeah.
address this for a week or two and see if they progress. And if they are, great, versus the people that are
Yeah, and
more
I
acute.
think if you're confident in knowing you have a good grasp on diagnosing and knowing what you're dealing with, and then you are confident in knowing you have the right tools in your toolbox to try and treat it. If you're getting improvements in 2-3 visits, like you can keep trying to get improvements. If you're 3 to 4 visits in and you're really not making much in the way of improvements, it's probably time to go ahead and refer them. They're probably not going to change all that much.
Yeah. Yeah, I like that. So last question I have for you, because I get also asked this question a ton, is, hey, how can I use PRP with laser or vice versa? And, my general response is the literature on PRP is pretty dicey in general. So when I start seeing really great PRP studies, then maybe we can start looking for good combined PRP laser studies.
Yeah.
But I just wanted to get your take on how you guys utilize it, if you utilize it in your center, and what kind of outcomes you've been seeing.
Sure. We do utilize it. I would say it is not like, it's not something that we're doing 5-10 times a week. We might be doing 1 a week, 2 a week. We are very particular on who we offer it to. I would say, I mean, in the years that we've been doing it, which is probably the last true PRP, not like some of the other precursors, which is probably the last 5 years or so, we have maybe done it in 10 hip joints. Like we don't really offer PRP into the hip joint for a multitude of reasons. Mainly, the majority of our patients who have intra-articular hip pathology are non-arthritic labral tears with associated FAI. So in theory, if the PRP can help heal a labral tear, which is theoretically possible if you think about it, that doesn't change the bony structure that caused the labral tear in the first place. So unless you're going to stop doing all of the movements that create that functional impingement that caused the labral tear in the first place, you're going to stop dancing, you're going to stop playing basketball, you're going to stop whatever, golf. The likelihood is, even if you do get a reduction in pain associated with some healing process, you go back to those activities, your pain's going to come back, and we just charged you, $800 or whatever it is, because it's not covered by insurance, to end up being like, yeah, you need surgery. So we don't tend to do it much in the joint. The ones that we do offer in the joint are either people who are just so good, they're like, I don't care what it costs, I don't want to have surgery, I want to try literally everything except surgery. And we're like, okay, as long as you understand that we don't think this is going to work, we could try it. And you could be the first. And especially if they don't have massive like cam impingement, or they're kind of borderline on the impingement side of things, then maybe. Just not very common. Or someone that's super arthritic and they've tried like hyaluronic acids, they've tried cortisones, and they're like, is there anything else I can try? And money is no object. Well, you want to try a PRP? Okay, like a total joint is going to be your best option, but so that's the joint side of things. The place we use it by far and away the most, and where we've had the most success, is with glute med pathology, glute med men. We use the Arthrex Angel kit system. So we make sure that it's concentrated appropriately and high enough for the patient. And we have the option of doing, leukocyte rich versus leukocyte poor, depending on like tendon versus muscle versus whatever. And Beth is the expert in that. I try not to.
Does that matter? Like, do you see differences in that?
Yes, absolutely. Concentration matters tremendously. And then depending on the actual tissue you're trying to inject around, leukocyte rich versus leukocyte poor also matters. And there are a couple of studies out of Australia that show some good results compared to 2-year outcome results with PRP compared to corticosteroid in glute med pathology. And so we have found in individuals with, mild tearing or significant tendinopathy who have failed conservative treatment, that being, a one-time corticosteroid injection and physical therapy typically, that going ahead and trying a PRP injection, we've had some good success with. And we personally, there's only been a couple of people where we end up doing a second injection. If patients get good, like typically they get better, and with the right therapy, they get better and they stay better. We've had a few that are like, well, I feel like I'm like 50-60% better. Like, can we do one more and see if that helps? And we're like, okay, sure. But we aren't big on the idea of like, oh, you're going to need a series of 3 and all of that. And we do utilize, we use the laser with those patients. But we wait on our PRP. We typically have them resume their therapy about 2 weeks, 10 days to 2 weeks post PRP, because really in that first acute, subacute phase, we just want that inflammatory healing response to start to occur. we want tissue to start laying down, and then we want them to come to therapy, and we want to be able to stimulate that tissue appropriately to try and get it to lay down the way we want it to make it, strong enough to withstand the forces that they're going to put through it.
Cool. So it's always good. I think PRP is evolving. I think that concentration issue, I've listened to talks on that too. I think the number I heard at the last one I was at was that you need 3 million parts per million or whatever the thing is to show concentration to have
and for
enough.
like every I don't want to misquote this, but it's something along the lines of like for every decade of life or every certain amount of years, like the concentration has to go up to be able to be effective. So like if you're dealing with a 50-year-old versus an 80-year-old, you have to even concentrate it more. And that's where and we're not going to talk about PRP research, but PRP research in general, if you look at anything from like, gosh, I think it was maybe 5 years ago, and backwards, it's kind of a waste because the majority of those studies didn't put their preparation in it. They just said we did PRP. It's like, okay, you could have like drawn the blood out, like shook it up a little bit and stuck it back in and called it PRP when that's not really PRP, like that's not effective. Where all of the reputable journals now have standards where if you're going to submit a paper for it to get even close to being accepted, you better have in detail exactly how you prepared that PRP so that someone who wants to replicate that can actually go do it, right? It's like same with any of our PT studies. Like you could be like, we did exercise, but you don't tell me like what exercise you did, how did you load it? What were the reps and set schemes? Like how can I reproduce that?
Yeah, my take on it is like having looked at papers on laser and a variety of different modalities over the years.
Sure.
Dose is so important. If you don't have dose right and you don't have replication abilities of your study, say here's how I did it, then you could have something very effective in your hands, but getting a bad result because you didn't dose it right. So I have a feeling. Yeah, PRP I think fits in that same box right now.
Exactly. And it goes both ways. Like you're going to get someone that takes one study that says it works and be like, it fixes everything. Right. And then you get one study that says it doesn't work, and you get doctors or PTs.
It's all garbage.
Right. It's all crap, but none of it works. It's like, okay, you can't throw the baby out with the bathwater. Like it does work. Like I've anecdotally seen it work, and like this is what we do. But yeah, so it's evolving. It is going to be the way of the future. Like it's not going away. It's only going to become more prevalent. And hopefully in a very positive way.
Yeah, I think it'll get there. It's too young right now. So I agree. It's got potential. They just have to get the dosing right so they can get some replication of some good outcomes, and they'll be there. Right. So I just put in a couple papers to talk about, not so much to go over the papers per se, but just because it sparks up a couple talking points I'm curious to get your take on. But, this 2019 paper by Aliat, it's a systematic review, and the big picture is they looked at high intensity laser, which is like the Light Force product, versus with exercise versus a placebo laser and exercise. So it takes the placebo part away. Right. And the nice thing is they looked at necks and backs in this, and they found that, imagine that the high power laser with exercise did better than when they didn't use it. So have you seen that same kind of thing in your clinic, whether it's a low back or a hip? If you're those patients that you're not throwing laser at, I know you use it on most, do you see changes versus the ones that you are using it?
Yeah, I mean, and I can just compare from like my pre-laser life and my post-laser life, right? Because like you said, it's not like we're like, well, we don't like that person, so let's not give them laser.
Right.
And I think it's twofold, right? Like, yes, I think we do get actual like true reduction in pain because, and for whatever reason. But I think even more importantly, maybe particularly over the long term, is that ability to get these people moving and get them like believing that they can be better as quickly as possible makes a really big difference. So while I think exercise for low back and neck pain patients is probably the most important thing, like if you can't get there because you can't reduce their pain enough to make them willing to move, you're stuck, right? At that point, then you just got to hope, like cross your fingers that with time, their pain's going to reduce and then maybe they'll exercise. But if we can make quick changes and get them feeling better and they're like, oh my gosh, and they buy into therapy, and you get them in and out the door in 4 to 6 visits instead of 12 to 20.
I think the couple things that are worth noting is you pretty much said that you like using it on almost every patient. Like
Right.
you don't like it when you can't use it on somebody. So I think
Right.
that says
I mean,
something.
it gets fought over in the clinic.
Right.
I mean, I sent you the picture the other day. We use it so much that I need a new thing for the wand because it gets taken off and put back on so much, it's like fell off.
Right. Right. And then the other piece, like in this study, it's the laser is a complementary modality. So this is not like it stands by itself and fixes everything, and it's not a magic wand, but it's a tool that can, when you understand how to dose it and use it properly, it can really help make things better and get people better quicker. And you hit it right on the head when you said it helps them have less pain so you can do more functional stuff and get them moving. So I've sat in so many of these discussions. I mean, at the APTA combined sections meeting where I listened to people stand up on stage and say, you know, modalities don't work, they're terrible, you know, we shouldn't be using them. And they're just completely missing the boat because they're representing it as it's this alternative path or this alternative therapy as opposed to all the other stuff that are involved with motion and getting people on their feet and moving because we know that motion is healing basically.
Right.
But I mean that point, I wish I could shoot those people, you know, with a bazooka to get them off that stage because it's so misdirected as far as that goes. I mean, what's your
Absolutely.
general take on modalities as a class, just on how it impacts your day-to-day life in the clinic, you know,
Oh my
laser and
gosh.
anything else
I
you
mean,
do?
and it's funny because I was a self-proclaimed like anti-modality person, not because I thought that like, you know, that they didn't, well, this was pre like, remember, not that I'm like super old, but my PT school modality education was ice, heat, hot packs, you know, stim and ultrasound. But enter high powered laser and, you know, other modalities like focus and radio
Shockwaves and yeah,
shockwave.
right.
And I'm like, huh. And I'm always open to trying things. And with both of those modalities, shockwave and laser, my practice changed immediately. It wasn't like I had to use it for months to be like, yeah, I think this does help. It was immediate change in my practice, my efficiency and my effectiveness in getting people better. So again, most importantly, how quick can I get you to not rely on me and or this said modality and get
Mhm.
you stronger, moving better, back to the things you want to do. And I'm very fortunate. I know this isn't always the case, but I think it honestly is more people than not do actually want to get better. Like some clinic, like, nobody wants to get better. Like my patients definitely 99.9% of them truly want to get better.
Right.
And I think in most PT clinics, people truly want to get better, but they've maybe had crappy PT experiences in the past. They've had crappy physician experiences. They're down on all of it. They're just
Right.
down. And so having a modality or modalities in your arsenal that can make quick changes where people like they can't deny it. They're like, I do feel better. It's not like I'm trying to convince them they feel better and it's this weird placebo effect. They're like, I feel substantially better. They want to move. And like you said, like movement ultimately is the answer to getting
Right.
them better and keeping them from coming back again.
Right.
At least for that problem, you know, they might get hurt, whatever. But so I with those particular modalities, yeah, I think it is an ultimate game changer in being able to quickly make that happen. So within session, and then how soon can I get them discharged and back to their life? Like nobody wants to go to therapy for months on end. Like, you know, I mean, we have a
Yep.
personal relationship with your daughter, and obviously I saw her for months on end, but she had an ACL reconstruction. Like that's a different story than someone with low back pain
Right.
who's sick of dealing with it. And they're like, I can't pick my grandkid up because my back has been killing me for 6 months or a year or 2 years. And if I can get them back to picking up their grandkid in 6 visits versus 10, 12, 20 visits without the use of the modalities, why wouldn't I want to do that?
I think it's worth noting too for background on your facility, you know, the fact you're calling out laser and shockwave is like, hey, these are things that really were game changers. Because of the nature of your center, you guys get to sample and test almost every toy that's
We do.
out there, right? So the
We do.
fact that those two stand out, it's not
Yeah.
just that those are the only two things you've ever been introduced to. Those are
Right.
the two that, you know, are head and shoulders
Oh yeah,
above
there's plenty of things that have come and
them.
gone. Like they
Yeah.
get packed back up in the box and they leave, or they get used for a couple of days, and my staff and me are like, eh.
Yep.
But like, you know, it's a detriment if you have this like new great thing and it's slowing you down in your clinical practice and you're not seeing any effect from it, it's getting sent back. Like we're not moving forward with that.
Yeah. And we don't have to talk much on this one, but it just points out, it supports kind of what you were saying about laser's benefit to help your acute patients. This is a 2024 study, so super current from Wang et al. And they looked at 42 different articles, 21 systematic reviews, and 21 randomized controlled trials, and take a look at everything that people are doing to address low back pain on the acute and subacute level. And for the acute, the thing that stood out to me on this paper, as I put it down here, is that low-level laser was the only modality that they endorsed for acute low back pain. On the subacute side, they were pushing exercise and manual therapies, spinal manipulation, immobilization, and soft tissue work. No big surprise. And as well as a few alternative things for the acute folks, Tai Chi, acupuncture, and taping. So if you're incorporating those into your practice, if you're skilled in, going down that road, I know you use dry needling, which isn't quite acupuncture, but it just gives a little support to what we've been talking about for the last half an hour. So
absolutely.
And lastly, this is a study, and the reason I just put this on here is it's a 2010, acute low back pain with radiculopathy study. So it sort of ties in that these folks are going to have back pain and hip pain, some of those things we were talking about earlier with Ashley. But, a very big N, they looked at 3 groups, 546 patients of a group that got NSAIDs and active and laser. Group B just got NSAIDs, and Group C got NSAIDs and a placebo laser. And what was interesting was that no big surprise, the laser and NSAID group did the best, statistically significant differences across the other 2 groups, but the placebo group did better than the NSAID only group. So there is a placebo component. I get it all the time. Oh, how do you know it's not placebo? This is nice, is that it shows, yeah, placebo did have some effect, but it didn't outperform the laser. So I think that's important to note. But anyway, the other point on this, which is a good one, is they're talking about radiculopathy. So you're talking about deep tissues, and that's where having the higher power devices, and this one didn't necessarily have a high power device, but having that makes it much easier to get dosing to big swaths of tissue. And like we talked about with the PRP studies, if the dosing's not right, you're probably not going to get great results. So whatever equipment,
and these were treated. These were treated 5. I don't know. It was 5 times 4 over the course of 3 weeks.
5 days a week for 3 weeks, right?
Oh, okay. So again, like a lower power, a lot of dose, like overall dose change. Yes. Higher power, like being able to have an immediate change. Like I'm using a high power at your lumbar spine, and your symptoms distally are changed. Like that's not your hip. I didn't do anything to your hip. So like, again, with educating our patients and just being able to put pieces of the puzzle together, having something that can make quick changes is nice.
Right. And we've talked about it in previous, webinars and what have you, but the high power has the ability to change pain quickly, very regularly. So the lower power devices struggle to do that just due to their power densities and such. But just understand, if you're using a low power device, it has a place. It's going to help with circulation and, some of the PBM effects that can address different aspects of the inflammatory cascade. But when you start dealing with the higher power device, your class 4 devices, you're going to see significant changes in pain within minutes of treatment in most cases, like Ashley's pointing out. So just understand there is a difference there. So I know that you're on a tight time schedule, Ash, so I appreciate you chatting with me. If people wanted to get in touch with you, you were kind enough to put your email down here, so you can reach out to Ashley directly there. If you want to talk to me, you can reach out to me as well at that email at mark.callanan@enovis.com. But if you're interested in if you're not experienced with the high power laser and you're interested in maybe getting a demonstration, just click on the QR code here or take a picture of it, and we'll be in touch with you in a day or 2 and get somebody out that can actually show you this, so you can touch it, feel it, and see what it does to a few of your patients. It's the best way for you to understand the power of it. So I'll leave it at that. And parting thoughts, Ashley, based on anything that came up or popped into your mind in the last 3 minutes.
No, I appreciate the conversation. I think we covered a lot of very pertinent aspects of what I deal with every day. And I hope it's got some people thinking and kind of reconsidering maybe their thoughts on modalities, and or feeling a little bit better about dealing with these kind of complicated hip patients.
Yeah, and I mentioned it, in my previous webinar, we were talking about throwing shoulders, but hip's another one of those. It's a really specialized thing. So to Ashley's point she made earlier, if you see somebody in your clinic, 3, 4 visits, and they're not progressing or not doing well, and they have a handful of symptoms or whatever that you're scratching your head and can't get your arms around, the best thing you can do is refer these people to a place that really sees this stuff day in and day out so they can get that person moving forward. They'll appreciate it. They'll most likely come back to see you for their next problem because it'll build trust and faith in your abilities. But it also it's just the best way to handle things. Ashley, thanks so much. Appreciate it.
Thank
I
you.
learned a lot. So hopefully our listeners did as well. And
Thank
we'll
you
look
very
forward to
much for
seeing you guys
having
again
me.
soon. Yeah,
Thank
it's always fun. Thanks, Ash.